no, because Karbowski's not lecturing. But from 10 to 11, I think somebody else is.
You mean from 10 to 11?
I mean, 11 to 12? No, 10 to 11, no, because Karbowski was supposed to be lecturing. And then from 11 to 12, yes, I think. Gotcha. Any plans for the weekend?
Nah.
Same. You want to see something funny? You want to see something funny?
What?
My friend just sent this to me. Oh, how's the policy going?
Good.
Are you working right now?
This is, it's called Sin and 5 Things to
Oh.
Chew Out from the Door.
The email alerts, right? They send it every morning. 真的想跟我讲一下这个事情。然后昨天跟小姑娘聊天了，然后呢，我说，哦，对，我今天去跟另外一个朋友喝奶茶，要去，左右一下，说这个喝奶茶，他说你儿子去洗衣服，我有2周没洗，没有吧？要不然我就说。
这就不是什么重要的。
哎，我就说，哎，我绝对没有骗你。就这个日，然后我就说，那你要想让你的 FE is more than 不是在 until the one who participates in the model。那你的 Facebook 朋友在上面发人人网。
一次吗？
不是，他是这节课就整节课呢，他就放了个 slide，他前面还有别的人，就照片前面是别的人，然后就发现所有的这些人，就我不在乎你贴不贴，跟你跟我有屁关系啊！而且我没想你，你还在自己的 profile 上面干啥？就传递这里时，然后我就说，哎，他不理我，我现在你要不跟我道歉，我这辈子不理你。你还能录吗？不是，我真的打不通，可能这个你不要很快就跟我讲，因为我听到看有个跟他讲那个马航，说他那个客气死了，他都是，他根本就不在。对，而且关键是，如果你知道我们群那个东西，你去年贴 PK 的时候，我都没有去上面去截他那个贴的。没有，如果有个学长提醒他就就。是很久以前我们有一个学生他是这样，他就说，我没有说这节课，我只说有个学妹，然后主要笑的是我跟他是就是他初中体检这节课，就他这里是突然跟我讲解这个10个运动，突然这节课才4天。他自己会现在自己也做出是一个天天在那上。这些是我回答不了的，我可以，我觉得就因为这些没有办法跟别人讲的原因，就是在于别人不会把日常当回事。但是他踩到我的底线，然后他明明知道我的底线在哪，他还去踩。3个人了吧？我不要跟他讲。他没有这个，我凭什么给他提出？他现在跟我说过。我给他讲过他学长的事情，我跟他说，我没有讲他到底学长骗我多少事，因为他是自己乱骗我，骗我好多事情。因为我不能给他太羞耻了。然后我就跟他说，就是他知道我喜欢他。
Yeah, that's like literally, it's like
然后他也知道我和学长告白了。好，然后
yeah, like right after they were
我
reporters, Tennessee
没怎么负担那个骗
is
他，他
really
就说
there
为你
in
负
that.
担得起那个
And they're really good
我
in
负担那个是谁？
Where have you been?
我说我给你个骗吧，我说
right
没
there
骗，
on
我
the
说我绝对没有骗。
But there's a valley program
他就觉得这不是什么大问题，他不知道会 overreact。
in
但是
they
我
were
就这个，我就是让他们我求你们不要骗。
Yeah, I really like it here.
所以这就是我的底线了。我说这是他好欺负，他觉得他自己其实你就是一而再再而三的试探的。
every barbecue's different, you know, it's
Yeah.
kind of just like basically comes down to what kind of barbecue sauce you like.
Yeah.
And theirs is I kind of like vinegar.
Yeah.
But no, I really like I love Tennessee, but they don't have one in Tennessee or in Georgia. So I was just trying to go around there. They're in South Carolina.
Well,
就关键我就很烦的点就是他根本没有放在心里的事情。因为我完全 数学3年。其实他这里边自己总结动词写的挺清楚，就是有时候那个题应该都差不多。我就很不高兴，我不是跟你讲过他要来接我，不是他对他来接他没有来接。然后就当然那天听到他接我特别好，因为是我想撮合我的朋友，所以他才一起，他也坐我旁边，然后我就特别不散，我就表现特别不散，他就看不出来。知道我的朋友受不了我自己家可能有些老师，我不要他是不高兴。是的，是的。然后他们说，你还想留他多少次？就他对自己是可以说的，
Okay, WebEx, join meeting.
Hey, students in Austin, can you say something from your student mic as a test?
If any of y'all are saying anything, I cannot hear you.
The volume's really low, but we can't hear you.
You can hear me?
Just barely.
Okay, John, if you can hook me up.
Yeah, we'll make adjustments. A lot of it is because probably the chatter in the room, but we'll also raise the volume.
Very cool, very cool. And can you all see my slides? No? John, they're not getting,
She's saying something. She's touching her control.
Oh, you want to share your slides?
yeah.
Are you plugged in on? You plugged into?
Yep, I'm plugged in. It shows that they're sending from my side.
Okay, there's a little share button there on the touch panel.
Yep, it's
PC.
yep, it says sharing call.
Yeah, under PC. I'm not
Uh-huh.
seeing it here either.
I'm going to do it again. I'm going to stop sharing and then reshare.
Oh, we saw it, Dr. Ryan, and then it went
You
away.
saw it?
Yeah, we see
And
it
then
now.
it went away. You can see it now? Bueno, thanks.
There we go. We see it now. Up here too.
Okay, we're going to go ahead and get started. During the class, if you guys have questions, please go ahead and ask them during the session. If you try and wait till the end, a lot of times you'll forget what it was you were going to ask. And if I don't see you like with your hand up or something, go ahead and click your button and stuff and interrupt, because I may or may not see that. And you guys got my slides okay? You guys can see them currently, and you have the copies of from Canvas? Just a thumbs up. Bueno. Okay. So I just want to introduce myself a little bit. I do not know most of y'all. So my name is Laura Jo Ryan. I'm one of the clinical professors down here in San Antonio. A little bit of background. I went to school. I sat in the same room you're sitting in many years ago. It looked a little bit different, but I went through pharmacy school here at UT, graduated with my PharmD, and then I did 2-year specialty residency on the East Coast. Then came back here to Texas, and I've been working, my specialty is internal medicine. I work at University Hospital. So for any of y'all that are coming down to San Antonio, when you do medicine rotations, you may very well have me. And you guys will see me throughout the courses of classes. I do lots of different internal medicine topics. I think you guys have me next for anticoagulation and maybe therapeutic lifestyle changes. And then you'll see me periodically throughout. But again, here's my there's my information and my email. Please don't hesitate to shoot me questions if you have them, okay? Don't wait until after it's a little too late, or, you really have a hard time understanding something, make sure you ask. So I realized I actually copied and pasted some of these learning objectives were not the ones I wanted to use. So we're going to look at the first 2, and then I'm going to send you another page with learning objectives. So I do want you guys to be able to differentiate between hypertensive urgency and hypertensive emergency and the things that fall under that, and also be able to describe the blood pressure lowering goals. I'm not going to ask you about the specific limitations of these drugs, so you can mark that one out. But I do want you to know if there are any specific contraindications. And then the last one, again, I will post this, but the last one will be, given a patient case, be able to apply the principles that we talk about today to that patient case and determine an appropriate pharmacotherapy regimen for that patient. So I know Dr. Karbonsky has talked about hypertension, different ways of managing hypertension. What we're going to talk about today, though, is the patient that comes in with very high blood pressure, somebody that, gives you that rut-row when you see how high their blood pressure is, kind of makes your heart go in your throat. So risk factors for having some sort of hypertensive crisis, that's what we call urgency plus emergency together, is just some sort of crisis. There are a lot of different risk factors, but those that have been identified throughout numerous studies: lack of a primary care physician, people not having regular medical care, regular checkups, somebody that's actually coordinating their care puts them at risk for this. It could be because nobody's catching their blood pressures elevated, or it could be because nobody's refilling their meds. Lack of adherence to antihypertensives. Obviously, if you have hypertension and you don't take your drugs, you're still going to have high blood pressure. Illicit drug use. This primarily goes along the lines of thinking about things like cocaine, methamphetamine, that sort of thing. But even illicit drugs that don't directly increase blood pressure, things like heroin use, marijuana use, stuff like that. When people are high, they don't tend to take their drugs the way they're supposed to. So it can be both a direct action of the drug they're using, or it can be that they're kind of too stoned to do what they should be doing with their regular medications. They may be going through withdrawal. So a patient who is a heroin addict, if they're going through withdrawal, their blood pressure may be through the roof. So that's something to be on the lookout for. Somebody comes in, you're not sure about their history, you don't know why their blood pressure is so high, thinking about that. People using steroids, both prescribed steroids as well as illicit steroids. The risk is probably higher with illicit steroids just because they're kind of using, doses that are not being regulated by anybody. But even people on prescription corticosteroids can have elevated blood pressure. And then anxiety or pain. Somebody gets in a motor vehicle collision, they're in a car wreck, they come in, whether it's anxiety, pain, both, blood pressure can go very, very high. So again, just kind of things to think about what's going on with your patient. So when we're talking about crisis, like I mentioned earlier, we have the two categories of urgency and emergency. If you notice, the blood pressures are the same. So blood pressure greater than 180 systolic or 120 diastolic. There's no difference in the numbers themselves. The difference is that you've got target organ damage in emergency. So my blood pressure is so high that it's affecting one or more organs in the body. Whereas in urgency, you're not having that. And as you guys know, most elevated blood pressure is completely asymptomatic. So that's the difference. That's kind of your dividing line. So when we're talking about our goals, the goals are very different depending on whether you have target organ damage. If I've got...
Can I ask a quick question?
Absolutely.
Sorry. On the last slide, so between urgency and emergency, can you tell at presentation if there's like end organ damage, or is this like classified after like some tests and stuff?
That's an awesome question. So we're going to talk about the different categories of target organ damage. Some of them people will complain about. Some of them you won't know until you've done testing, and we'll kind of hit each of those. But that's exactly what you should be thinking is you have this elevated blood pressure. What do I need to know? So if you have urgency, if you've gone through and you said, you know what, I do not believe you have any sort of target organ damage, our urgency goals then are actually fairly lax. You want to reduce the blood pressure, but you can do it within hours to days. And the 2017 guidelines recommend getting to a goal eventually of less than 130/80. And I mentioned that that's a specific guideline there because there's a lot of controversy about this. There are some guidelines that will say, you know what, we just want you to have blood pressure of less than 140 systolic, going with normal goals. I'm not going to try and trick you guys with questions like that. I'm going to give you, options of maybe getting them to less than 180 or getting them to less than 120. So there are going to be obvious parameters around there. Things you do want to do, though, is you don't want to drop their blood pressure too quickly. Okay, again, you're not having any target organ damage, and dropping their blood pressure too quickly can cause several different adverse events. I have some of them listed here, but cerebral ischemia is a big one. If somebody has been walking around with a blood pressure of, say, 200 systolic for 6 months, and you drop their blood pressure to 120 systolic, they're not going to perfuse their brain very well. So you want to make sure that you're not causing any sort of ischemia. Same thing with cardiac system. You may not be perfusing their heart well enough or their kidneys. You know, you guys know from Dr. Moot's AKI lecture that abrupt changes in volume will drastically affect kidney function. Well, this will do the same thing. Even though we don't consider a systolic of 120 as being hypotensive, compared to walking around with a systolic of 200, it's very hypotensive to the body. So you will have a kidney injury. So you obviously don't want to do that. Don't want to give them more problems than they have. So since you can lower it slowly and not drastically, this is something that can be managed outpatient. You know, even just moving somebody into a calmer area can drop their blood pressure. If it's somebody that's been on blood pressure medications and they stop taking them for whatever reason, restart them. You know, this is kind of a duh kind of moment there. But go ahead and restart their drugs. Or if they're not taking them, find out why. If they're having adverse events and that's why they're not taking it, then you might want to think about a different drug. I've had several patients, particularly when I was a resident. I worked at a clinic during my residency that we had people that were very non-adherent to their medications. And I had a guy that would regularly come in with blood pressure running 220 or so because he wouldn't take his clonidine, and one of his care providers kept prescribing clonidine for him, but he really disliked the drug. So we finally found him something different, but we would use clonidine acutely to get his blood pressure out of the danger range. So you're going to restart meds, increase dose, or change potentially. If this is somebody without known hypertension, then you want to go ahead and give them an antihypertensive. If you have somebody that's starting out with a blood pressure of, you know, systolic 180, 220, something like that, you're not going to get them anywhere close to goal with just one drug. We typically start a couple of drugs, but again, you're not going for a drastic reduction right here. So I don't need to use an IV drug. I don't need to hospitalize these patients. If somebody has a systolic of 220, though, I'll probably give them something and make them hang around clinic, just so I can keep an eye on them, make sure they're not going to have a problem. I don't want them going home with a systolic of, you know, 200, and then they need to follow up within a couple days. So for people that do have target organ damage, these are the things we're thinking about. You know, we're thinking about head, cardiovascular system, lungs, kidneys, and then a few other things. So for neurologic, if somebody seems confused, you're going to be thinking that they're having neurologic damage from this hypertensive crisis, unless you have another reason for that confusion. You know, if it's somebody being brought in, they have a history of Alzheimer's, and, you know, whoever brings them in says, no, this is their baseline, this is their normal, you'd be less suspicious of it. But if it's a new onset change in mental status, you're going to make the assumption until proven otherwise that this is related to the hypertension. You might have acute intracranial bleeding, so subarachnoid hemorrhage or an intracranial hemorrhage. You're not going to know that without imaging. So if you suspect anything that looks like a stroke, you're going to immediately do imaging. And that kind of kills two birds with one stone. One, it tells you whether they have had a stroke or not. It also will tell you whether it's cerebral ischemia or if it's a hemorrhage. And we'll talk about kind of the different presentations of those in a little bit. New onset seizures with a blood pressure like that. If it's a new onset, you're going to assume it is related to the hypertension. But remember, if somebody has a seizure disorder and they're actively seizing, their blood pressure is probably going to be high also. So it can be a little misleading there. For cardiovascular, one of the things we see is aortic dissection, and we'll talk about that one separately because that's kind of a whole separate critter. They might have a myocardial infarction, or they can end up in heart failure. So left ventricular dysfunction is what the LV dysfunction is. For pulmonary, if you have a lung infarct, you can have acute shortness of breath. You can also have flash pulmonary edema, which is a severe emergency. I mean, they're going to go to the ICU. This is fluid on the lungs, and it can kill people very quickly. and you can have just respiratory failure overall. For renal, obviously you can have an acute kidney injury, and you can have, in somebody that already has chronic kidney disease, you can have an acute on chronic. A couple of the other things we see, preeclampsia or eclampsia in pregnant women, we'll talk about that as a separate issue. You can see changes in vision, so retinopathy. Okay, this is one that's really important to be able to differentiate, is this change in vision a symptom of a stroke? Or is this just blurred vision? So people come in with new changes of vision, you're going to be thinking about other stroke symptoms. I know Dr. Duhan's going to talk to you guys about stroke, so we're not going to go into other stroke treatment modalities, but just making sure you're determining what's going on. So in general, when you're thinking about a hypertensive emergency, you want to decrease their blood pressure, and we're usually referring to systolic here numerically, by about 25% in that first hour. Okay, so somebody comes in with a systolic blood pressure of 200, you want to bring them down by about 25% in that first hour. So this is going to take some sort of IV medication. You're not going to get there with oral. The next 2 to 6 hours, you want to bring them down to about 160 systolic at least. And again, these numbers are kind of soft. We don't have good, large randomized clinical trials showing that this is where we get benefit. Do you have a question? Okay, for some reason my camera just zoomed in on y'all, so I thought somebody might have a question. Not sure why we're zoomed in. Yeah, so again, these are not hard and fast. These are the goals, but if you have somebody and you don't get, that 25% drop within that first hour, it's usually not going to be something that you're panicking about. Now, if you can't get their blood pressure to drop at all, that could be a problem. And then over 24 to 48 hours is where you're going to try and get them back to a normal blood pressure. And again, by normal, we mean less than 140 systolic. Caveat on that is we have a lot of patients that just walking around, we aren't able to get them to that goal of less than 140 systolic. So again, getting them back to a safer baseline blood pressure is what your goal is. We're going to talk about these exceptions as separate issues. So just in general, hypertensive emergency is going to require admission to the ICU. You need to have intense monitoring, and you're going to have IV antihypertensives. It's not that you can't do IV antihypertensives on the floor, but depending on what they've got going on, it may be that they need a higher level of care, and you get admitted to an ICU. You also have the availability then of invasive monitoring if you need it. You're going to be thinking about, what is my most appropriate drug for this patient? So do I need a beta blocker? Is this somebody that has heart failure? Do I need a vasodilator? So you're thinking about all their other concomitant disease states. We've got beta blockers that are pretty good when we give them IV, but in general, just because somebody was on an oral beta blocker doesn't mean I'm going to go that direction. When I've gotten to the point of hypertensive emergency, I'm not really concerned about the previous antihypertensives they were on, unless there's a specific reason, if they had an allergy, something like that. Okay, so for our beta blockers, you guys do not need to know doses on this. Okay, but I do want you to know the selectivity of my drugs. I want you to know, is this something that I get a very fast onset and peak? So like Esmolol, I'm going to have it dropping my blood pressure within a minute or two of giving it. Okay? And then it's going to last only 10 to 20 minutes. So I can turn it on, turn it off, turn it up, turn it down very easily. I can really titrate that very tightly. Labetalol, I get really good blood pressure lowering because it has alpha and beta effects. Takes a little bit longer to hit, peaks in about 15 minutes, and then lasts for out 2 to 6 hours, again, depending on the patient. So I cannot turn it off quite as easily as I can Asmolol if I overshoot my blood pressure and drop them too low. Okay, the thing I do want you to notice also, like all beta blockers, I'm going to have a decrease in cardiac output. So depending on what this patient has going on, this may or may not be my best drug. Okay, so yeah, I'm not going to go there. Never mind. Okay, so for my vasodilators, when I'm thinking about my vasodilators, I'm wanting something that will drop my blood pressure fast. Okay, so we use hydralazine all the time, just in people with refractory blood pressure that I can't get their blood pressure down easily. A couple caveats on this. Again, you don't have to know specific doses, but I want you to know kind of relative onset and my problems with it, contraindications, that sort of thing. So hydralazine is fairly unpredictable though. Okay, so even though I usually get a good blood pressure drop, there are some patients that don't respond at all, and then there are others that will sometimes over-respond. You know, I give them 10 milligrams and their blood pressure just drops like a rock. So it's something to be very careful with. Nitroprusside, has Dr. Kaboski hit nitroprusside yet? Have you guys learned about this one yet? No? Okay. So this is a very, very potent drug. It has a couple of problems. So one, if it's used for a long period of time at a high dose, and particularly in somebody with renal dysfunction, you can have cyanide accumulation. So you basically end up poisoning your patient. Okay, so the thiocyanate is a huge problem if you're using it, again, high dose. And when I say long-term, I mean like 72 hours or so. And particularly in people with renal dysfunction. So if you guys were to see a patient case where somebody comes in and, you know, talking about, you know, their blood pressure is very high, they're having acute kidney injury from the elevated blood pressure, and you're given the option of nitroprusside, and I'll put something like high dose, medium dose, low dose, again, because you don't have to know the doses for several days, versus something else, you should be thinking, that's probably going to be toxic. Okay, that's the way I want you guys thinking about this. Nitroprusside can also increase intracranial pressure. So if you've got somebody that has ischemic stroke, something like that, or if they have a hemorrhagic stroke with high pressures, it might be something you want to avoid. You don't want to worsen that, obviously. Nitroglycerin, again, another vasodilator. It has pretty good, pretty predictable effects, but you will get tachyphylaxis to it. So you'll be using it and you'll start losing effect. So you'll have to keep an eye on those doses and keep cranking them up a bit. It also has more venodilation than arterial vasodilation, and people will tend to get a really bad headache with it. So nicardipine and clovetapine are two of our IV calcium channel blockers, and each has their own issues. So they're both very potent. I can get really good, fast blood pressure lowering that I need. Nicardipine, though, because it can be so potent with dropping blood pressure, I can get a reflex tachycardia. So because the blood pressure is dropped so low, heart rate goes up to compensate for that low blood pressure. So you may see that increase in heart rate. And then clovetapine is provided in a fat emulsion. So if you have a patient that has a soy or an egg allergy, if it's very severe, they may react to this. Again, very rare, but something to keep in mind if you have a patient with the drug allergy. Other miscellaneous agents. So enalaprilat is just a prodrug of an ACE inhibitor, prodrug of enalapril. It is something that can be used. It's not used real commonly. It has a pretty long half-life, and people have kind of variable responses to it. The other thing with it is how are our ACE inhibitors metabolized? How do we get rid of them? Okay, somebody has to answer. Have you guys seen the ACEs yet? I know Carla's, or Dr. Vandenberg's at least talked about them.
Just a guess, maybe through your kidneys, urination?
Absolutely. Absolutely. So we metabolize, or we eliminate our ACE inhibitors renally. Okay, and so if I have somebody that's in danger of having an acute kidney injury, I may not want to give them a drug that's going to be renally eliminated and accumulate in renal disease. So it's, you know, a consideration. It's not saying that I'll never use it, but may not be something that I really want to use. Phentolamine is an alpha antagonist, so it blocks my alphas. It's non-selective, so it blocks alpha 1s, alpha 2s peripherally. We use this specifically for catecholamine-induced hypertension. Okay, so the only time you'll ever see it used is in pheochromocytoma that we'll talk about later. So if I give you that as an option for somebody who hasn't been taking their blood pressure medications, it's probably a pretty good guess that that's not what you would choose. That's the only place I've ever seen it used is in a pheo. And then phenoldiprem, I just have this up here just so that you've seen the drug because I don't think anybody else is going to talk about it. This is a selective dopamine agonist. It is not used very commonly at all. It causes reflex tachycardia. It can cause low potassium and can increase your intracerebral pressure, intracranial pressure. So it's not used very often. On that one, I just want you guys to recognize the name and that it's a dopamine agonist. Okay, so that's just kind of a completeness sake. So again, in urgency, we're going to look at oral drugs, okay? I don't have to lower my blood pressure really fast. I don't need really super potent immediate lowering, so I'm going to use an oral drug. I'm going to lower it fairly slowly. I don't want to drop it really fast because then I have the problems of essentially risking other organs by dropping my blood pressure too fast. Emergency, going to go to the unit, going to get IV drugs. You want that blood pressure to drop now and fairly fast. And you're going to keep it around 160-ish for about 24 hours or so. Again, this is going to vary depending on the patient. And then you can transition them over to oral meds. So any questions about the basics? I know we went through that pretty fast. What we're going to move into now is some of the very specific hypertensive emergencies.
Yeah, I've got a quick question. Given that ACE inhibitors are sometimes the preferred treatment for, say, like diabetic patients with, you know, glomerular nephropathy, why is it only the extreme hypertension that's a concern and the reason that you may not, in that particular situation, use them? Yeah, that's exactly it. So it's not to say that I wouldn't transition somebody to an ACE inhibitor later. I'm just not going to use the enalapril IV. I have other better drugs that are easier to use and they kind of have more experience in that area that you know, people are comfortable titrating esmolol and labetalol. They're not as comfortable with the enalaprilat, and you don't have as predictable as a response. That's not to say that I wouldn't say, okay, I got you under control on esmolol. Now to get ready to go out, I'm going to switch you over to, say, chlorthalidone and enalapril or lisinopril, especially, like you said, if you have diabetes. So, yeah, this is just the acute phase. Other questions? Okay, so what we're going to do now is we're going to talk about...
have one.
Oh, yeah.
Sorry.
Yeah.
So besides like the specific cases we're about to go through, like, how do we know which one we should start with, I guess? Do we have to know, like, for, like, should we start with a beta? Do the people normally start with a beta blocker versus a vasodilator? Or besides those specific, like, oh, this is for phytocytochrome, yeah, the one that you mentioned.
Mm-hmm. Yeah, so on a case that I would give you specific hints. I'm not going to ask you to differentiate between, you know, would I use nitroglycerin, would I use nitroprusside, unless I'm aiming you at a kidney injury, something like that. I don't expect you to know the differences between those two unless there's a specific contraindication or a specific reason not to. What I want you to be able to do, though, is say, oh, if I have a patient, I tell you that they have severe asthma and they've been having some respiratory distress when they come in, some shortness of breath, and their blood pressure is 220, you should be thinking, do I really want to use a beta blocker in this person with severe asthma? I might make it worse. So thinking about those type of contraindications, okay? Or if I give you somebody has an allergy to something that's related. Does that answer what you were asking?
Yes, that was good.
Okay, good. Okay, so we're going to move into some of the specific situations here. First one we're going to hit is aortic dissection. And I'm assuming you guys have not seen aortic dissection before. Is that correct? I'm guessing. Nobody's talked about it. So there was actually a case on the news yesterday where an EMT that was driving an ambulance had a stroke, and his fellow EMT went in to help him, and he had an aortic rupture. So a very weird situation, but it was on the news yesterday. I was like, what timing? So what's happening in an aortic dissection is basically you're tearing the aorta and you end up with blood within the lumen. So it's coming out or outside the lumen. You essentially develop a blood pocket outside the vessel where it should be. You guys do not need to know the different types, and the DeBakey and Stanford are just different ways of delineating the aortic dissection, but this is an absolute emergency. People bleed out and die within minutes from this. Actually, one of the first codes I saw as an intern, I was grabbing a soda in the, I guess the lunchroom, whatever, at the hospital, and I heard something go clunk, and I turned around and there was a guy on the floor, and somebody was immediately calling a code, but he had a abdominal aortic dissection, and he died before they ever got him off the floor there. So this is an absolute emergency. So a couple things you're going to do. You're going to give them morphine because it hurts. Okay, so if somebody has one that's not a complete dissection, they're able to speak. What they'll usually complain about is severe chest pain that goes through their shoulder and their back. So it refers to the back. And it's just a screaming pain. And you can imagine they have a vessel that's ripping. So blood pressure, get it as low as you possibly can while still maintaining perfusion to the brain and to the cardiac system. So we tend to try to go for a systolic of less than 100 if possible, but we want to maintain mean arterial pressure, so the MAP. And have you guys gone through MAP yet? I looked back in slides and didn't see anybody that gone through MAP. Is that correct? Okay, so I will post this afterwards then. And what I'll do is I'll just post a set of slides that says blue slides. So don't feel like you have to write this down. So when we're talking about MAP, what we're looking at is exactly what it sounds like, the average arterial pressure throughout systolic and diastolic cycles, okay? So when you look at MAP at the exact definition, it's, cardiac output times systemic vascular resistance plus the central venous pressure. Well, we don't know any of those. You have to have invasive monitoring to know those. So what we do is we estimate it down here. So a normal MAP is 70 to 100. We use the number 60 as our goal of you need to keep a MAP above 60 to perfuse the brain, to perfuse the kidneys, to perfuse the heart. And so we can estimate MAP using diastolic blood pressure plus a third of systolic minus diastolic. Another way to do it, and again, these are the exact same formulas, just rearranged, systolic plus 2 times diastolic divided by 3. Okay, so it's just a way of averaging your systolic blood pressure with your diastolic and the time that is spent within that cycle, within the cardiac cycle, is all that is. But I will post that. So again, we want to maintain our MAP at least 60, even though I'm lowering my blood pressure as much as I possibly can. I don't want to lower my blood pressure so low that, they're not perfusing their brain and they die from that. That's, kind of defeats the purpose a little. The other thing we want to do is we go for what they call anti-impulse therapy. So impulse is exactly what it sounds like. It's an impulse. So how strong, when you go through that systolic portion of the cardiac cycle, how strong is that blood pressing against those vessel walls? So I want something that's going to lower that, because again, I mean, I've torn my aorta. I don't want something, you know, hitting it like a fire hose. So we need a drug that's a negative inotrope, so strength of cardiac contraction, negative chronotrope, timing of cardiac contraction. So what drug hits both of those? What drug class, I guess? So I'm decreasing my heart
Beta
rate.
blockers?
Yeah, beta blockers are exactly it. So they're negative inotropes and negative chronotropes. Okay, the options, obviously this is an emergency, so I need an IV drug. So I'm going to go with esmolol or labetalol. Okay, again, sometimes it's going to be site specific. Some sites will always use esmolol, others like labetalol. It's got, again, your alpha blockade, so you can get good blood pressure control. You could also use nitroprusside here. So if I had somebody that had an aortic dissection and I knew they had, you know, severe asthma and I was kind of skeevy about using a beta blocker in them, then I might think nitroprusside might be my drug. If I had the same thing, but they had terrible kidney function, I might go with a non-dihydropyridine calcium channel blocker. So what two drugs are those? So my dihydropyridines are like nicardipine, nifedipine, amlodipine. So which two are my non-dihydropyridines?
My friend said diltiazem.
Your friend said diltiazem. I like it. Your friend is correct. Diltiazem is one of them. What's my other one?
Verapamil.
Verapamil, absolutely. So those are my non-dihydropyridine calcium channel blockers. Okay. So now knowing that, you know that your non-dihydropyridines are also negative inotropes and they're negative chronotropes. So when you guys get to heart failure and they say, well, we don't want to use that drug because it's going to cause problems, now you know that these are not good drugs in heart failure because they're negative inotropes and chronotropes. But in this instance, they're great for somebody who couldn't tolerate a beta blocker for one reason or another. You know, if I've got somebody, say, you know, their blood pressure is high, they're having aortic dissection, but their heart rate is 50, I'm not going to want to start a beta blocker. I'm not in love with starting a non-dihydropyridine calcium channel blocker either, but that might send me along the line to going to nitroprusside. So I'm not lowering my heart rate. So thinking about all the aspects of what the drug is doing. But again, cyanide toxicity in nitroprusside is a real thing. And then obviously you're shipping them off to surgery. This is not something we handle pharmacologically. They ship them off to surgery and they basically take and wrap this whole thing in what looks like a big bandage or cast. It's a flexible mesh that provides support. Questions about aortic dissection? Okay, so our next one is pheo. So a pheochromocytoma is something that when I learned about it in school, they told us, you know, this is just theoretical, you'll never see it. Yeah, I've seen like 4 at my hospital this year alone. We see it. We're a big enough hospital system that we do see it, but you will hear people say, no. Now, if you work at a little tiny place out in the country, you might never see one of these. So what this is some sort of tumor that is secreting, for one reason or another, epinephrine, norepinephrine. So you have catecholamine overload, okay? A lot of times they're adrenal tumors. That's what they usually are, but they don't have to be on or in the adrenal glands. And the kind of mnemonic for this is pheo. So people will have palpitations, they'll have headaches and episodic sweating. So even though the tumor is secreting these catecholamines, it's not 100% of the time, all the time. Okay, so it can ebb and flow. So the first thing you want to do is get stability. Okay, make sure they have plenty of fluids, and then you start controlling their blood pressure. So the important thing about this is you're going to use an alpha blockade for their blood pressure. Okay, when you think about what is controlling the blood pressure in this situation, because they have such high epi and norepi levels in the body, catecholamine overload, you're hitting both your alpha and your beta receptors in the vasculature. When you hit the alpha receptors with norepinephrine, you have vasoconstriction. If you hit the beta receptors in the vasculature, what does that cause? If you have beta agonism in the vasculature, what do you get from that? Take a guess. Remember, most of the body systems are a balance, counterbalance thing. So if I'm getting vasoconstriction from alpha, what do I probably get from my beta?
Vasodilation.
Yeah, exactly. You get vasodilation. That's exactly. Now, the vasoconstriction you're getting from your alpha agonism is much, much more powerful than the vasodilation you're getting from your beta. That's why your blood pressure is so high. But if I give a beta blocker in this situation, instead of an alpha blocker, what I've done is I've taken away any vasoconstriction I get from my beta by giving a beta blocker, and my blood pressure will actually go up. So if I give a beta blocker here, I can potentially kill the patient because their blood pressure will go sky high because now there's nothing to balance that alpha agonism. Can anybody think of another situation where you might have uncontrolled norepinephrine release, uncontrolled, essentially catecholamines other than a FeO? Like some sort of drug use? Kind of illicit drugs do you think of that are associated with extreme hypertension?
Would it be like cocaine or something?
Absolutely, absolutely. So cocaine overdose, even potentially methamphetamine overdose can cause very similar outcomes, and it's kind of one of those classic syndromes that they talk about. Again, you're going to avoid a beta blocker. So your blood pressure target is fairly low. You're looking at a target of less than 120/80. You do want to make sure your patient's maintaining their volume. So you give them lots of fluids and have them eat sodium to keep the volume in the vessels, but you want to drop the blood pressure. So this is where the phenoxybenzamine comes in. This is the one I said this is the only time you'll use it, back on those charts under miscellaneous. It's kind of the traditional drug of choice. It doesn't mean you always are going to use it. You might use just a regular old alpha blocker because they will lower blood pressure very well. People don't tolerate them very well because they lower blood pressure so abruptly. They're tolerated better long-term than phenoxybenzamine is. Phenoxybenzamine makes people just feel like crap, honestly. And they don't like it, and then they stop taking it, and their FeO's still there. So usually what we're thinking is, you immediately give them phenoxybenzamine to get them under control, then put them on a selective alpha blocker, or if you can get them under control with doxazosin, something like that, you can do that too. There's no absolute right or wrong, but you may not get blood pressure control with your selective drug. If after your alpha blocker is on board, they're still very tachycardic, then you can add a beta blocker on to control the tachycardia. But you have to have that alpha on before, because otherwise, like I said, you get that unopposed alpha stimulation. And this is traditionally getting them stabilized to get them into surgery. You've got to get rid of the tumor. So don't get tricked by a question on an exam that has you giving a beta blocker first, okay? So we're going to switch off FeO. We're going to go to preeclampsia and eclampsia. So when we're talking about preeclampsia, eclampsia, it's the same disease state, just taken to a further level. So preeclampsia is going to be hypertension that's specifically gestational. So after 20 weeks gestation is where we see it. And it's defined as just the same numbers as traditional hypertension. But they're also going to be spilling protein into the urine. or they're going to have thrombocytopenia, renal dysfunction, hepatic dysfunction, pulmonary edema, or CNS disturbances. Okay, so it's blood pressure elevation plus either kidney injury or renal, hepatic, CNS, or platelets. Okay, you do not have to know the specific numbers. I'm not going to give you something like they have thrombocytopenia and their count is 103K and then have it not count. I'm going to make it obvious. I'm not trying to trick you, but I do want you guys to know the information. Okay, so again, this is something, new onset hypertension, proteinuria, or organ dysfunction. When you have severe features, your blood pressure is even more elevated. You definitely have some sort of systemic involvement still, and you may have what's called HELLP syndrome. So HELLP syndrome is really defined by the hemolysis. So you've got hemolysis, increased liver enzymes, and low platelets. So you've got the thrombocytopenia, the hepatic dysfunction, but hemolysis is what really defines this. And this is something that will recur in women sometimes. So if you have HELLP syndrome with a pregnancy, you're much more likely to have it with a next pregnancy. So it's something that puts women at very high risk for subsequent pregnancies as well. And what defines eclampsia is you've got preeclampsia of any level plus seizures. So once you hit the point of seizures, it's classified as eclampsia.
I have a quick question.
Yeah.
Is HELLP the same thing as DIC?
HELLP and DIC are not the same thing. It is somewhat similar, but you don't necessarily have hemolysis in DIC, but you will have very, very low levels of fibrinogen, which you don't necessarily have in HELLP. But they can look very similar, but it'll be classified as HELLP if you've got the hemolysis. And DIC is very much a diagnosis of exclusion. We don't know what the heck's going on. Oh, look, we're going to call it DIC because there's nothing else to call it. So the traditional drug of choice that you'll see on lots of standardized exams for pregnancy or for hypertension during pregnancy is methyldopa. So methyldopa is a central alpha-2 agonist. So what drug does that sound like? What's the other central alpha-2 agonist we use for blood pressure?
Clonidine?
Yeah, clonidine. So we know that people don't tolerate clonidine well, makes them feel like garbage. Guess what? Methyldopa does too. Okay, so it's the traditional drug. It's the drug we probably have most literature about, most evidence for. There are very few OB-GYNs that will use it just because people feel like garbage and they're not going to take it. But if, like on a NAPLEX exam or something like that, if you would see it, it's probably the right answer. Causes edema. Well, these women already have edema. I mean, they're pregnant, for God's sakes. They're usually fairly edematous to begin with. So again, traditional drug of choice. What we actually use, though, we use a lot of nifedipine. Labetalol can be used, but again, you may cause orthostasis or hypotension, and it does cross the placenta. So if you're using higher doses, you may cause the fetus to be bradycardic. So what we're seeing a lot of, though, is nifedipine. Nifedipine's it's not specific to this. You could use a different calcium channel blocker, but the evidence is there for nifedipine. It does cause some peripheral edema. So if she already has fat feet, it may make it worse. And it has tocolytic action. So tocolytic action is a decrease in uterine contractions. So if you have somebody who has threatened preterm labor, she's starting to have contractions, you get kind of double bang for your buck here of having that tocolysis. So again, you've got preeclampsia that has very high blood pressure, that severe range, 160 systolic, sustained, or they have some sort of cerebral hemorrhage. This is huge. I was blown away when I saw that it's 2/3 of maternal deaths in a UK registry are from cerebral hemorrhage with preeclampsia. I was very surprised by that. If you get to that point, you need something that's fast. So IV labetalol, very good, same adverse effects. IV hydralazine can be used. It can cause maternal hypotension, again, because you can have severe hypotension. And there's less evidence in the emergency area for using the calcium channel blockers. Again, nifedipine, lots of good evidence for using it longer term, less evidence when using it IV. Okay, so, for that emergency.
Right.
If you get to the point of
Can I ask a question real quick?
Absolutely.
So for mild or moderate, which is like a non-emergency, we would tend to not use labetalol, but for emergency we would, just because it's faster?
Yes, exactly. So, it may be that they use labetalol. I mean, it's certainly an option. Most practitioners prefer the nifedipine for long-term use. But if you get to emergency, you need something that's going to hit fast. So, exactly right. If you get to the point where mom has had a seizure or she's threatening seizure, we use MAG. Okay, so we use this either to prevent the seizures or as prophylaxis against another seizure. We give a huge IV load. You can give it IM, but only if you don't have a line. It's extraordinarily painful. Okay, so unless you just don't have a line, and then you better get a line and not do it again. So we give a big load, give them infusion, and it will drop blood pressure like a rock. It will also cause flushing. So mom will be hot as all get out. I have a friend who actually his wife was on a MAG infusion, and they had the room at about 50. And she's, over there still fanning herself and dying, and he's sitting there shivering and freezing. So causes severe flushing. It will decrease the recurrence of seizures and decrease mortality. So MAG is your friend in pregnancy in this situation. Unfortunately, none of this cures preeclampsia or eclampsia. The only cure is delivery. You have to deliver that baby if they're having an emergency. Okay? And I know we're running up on time, so I'm going to kind of go through these last couple fairly quickly. And then I have some cases I'm going to post for you guys so you guys can walk through. So stroke, you guys are familiar with what stroke is. But when we're talking about it in terms of hypertension, hypertensive emergency, you need to know if you're looking at an ischemic stroke or hemorrhagic stroke. So ischemic stroke, you're talking about either a thrombus, they threw a clot to the brain, or hypoperfusion, you're not getting the blood there. You can have an ischemia, just a shutdown of the artery, again, or a clot. So I'm not going to steal Dr. Duhan's thunder. He's going to talk about TPA. So if you have somebody that has a clot in the brain, you give